So what are these steps? What's involved with surgery? Well, the hardware has three components to it. There's the deep brain stimulation electrodes that go inside the brain. There's a battery lead extension that's thicker than that, and that's important because you don't want these very thin electrodes going all the way down here, because if they break, then you'd have to start all over again. So we have these thicker battery lead extensions that go underneath the skin, connect to the battery, and then there's the battery itself. And you may hear us refer to the battery as an IPG, an implanted pulse generator. Basically, it's a pacemaker-like device for the brain. Now, anyone going through this procedure is going to go through a number of steps. And for us to do this procedure properly, we have to be able to get good CT scans or preferably MRI scans. We need to see where certain structures are. We don't do pneumoencephalograms any longer, so I don't even ask for one. You're not going to get one. But we need to be able to see these things. And so we haven't had any problems with even people that are claustrophobic. It's not been an issue. We'll give you some sedation for the MRI scan. Typically, we do the MRI scan before the procedure, and then after and during the procedure, we'll do a CAT scan. We'll merge the two together in our planning computer and get the best of both of those technologies. Brain mapping, microelectrode recording is another term for this. Basically, we want to get an electrical signature of where we are in the brain. The imaging can't see many of these structures. The subthalamic nucleus is probably 6 millimeters long, 4 millimeters wide at its widest point. We're talking about a plump grain of rice, not much bigger than that. You just can't see that on everybody on the MRI scan. Even with the 3 Tesla magnets, we're seeing it more, but you can't rely solely on the imaging. So it's important to get an electrical signal of where we are, and I'll show you some diagrams of that. And why is that important? Because the effectiveness of this procedure is directly related to how good you can target these structures. You don't want to get it near that place where you want it. Because if you get near that place, then you're going to have to increase the voltage. You're going to stimulate the undesirable areas. You're going to get side effects. And it's going to limit what you can do. So you want to be as precise as possible. Once we know where we want to put it based on the mapping, then you actually put it in there. And once the lead is in there, so you go ahead and test it by connecting it to an external battery. And we can get some idea of what kind of effect you're going to get, what kind of voltages are going to be effective, and then if we really crank up the voltage, what kind of side effects you might get if we do that. And that's all done in the operating room. And we close up, and you come back for a separate procedure and put the battery in and the lead going to that. And then there's a honeymoon period. There's a period of time where you have what we call a micro-lesion effect. And so just the inflammation of placing those electrodes, you actually get a benefit for several weeks. So it's actually several weeks later that you turn on the batteries because you want that benefit to fade and go back to your baseline. So this is a process. This is not just showing up one day, having an hour's worth of surgery and going home. You're going to go through a 3-stage procedure, and it's going to take a month for it to really be completed. And it's important for you to know that if you're considering this. We've had nobody chicken out. Once they decide to do this, they all do fine, because it's really not that bad, believe it or not. This is the frame that we put on. Come in that morning, nothing to eat or drink, no medications on board. We want you at your worst. We put the frame on under local anesthesia. You can have a little sedation for the frame placement, but the sedation has to wear off for the procedure. And then you go off to CAT scan with that frame on. The frame is a fixed size. We know exactly how big that frame is. And if we can figure out the position of that frame relative to the position of structures that we're targeting, we can get very, very accurate coordinates in the X, Y, and Z plane about where these structures are. In fact, the frame is about 10 times more accurate than the MRI scan is. So the MRI scan is the limitation in how accurate you can be with this. Since accuracy is paramount, you have to use some sort of stereotactic procedure, whether it's a frame or one of these newer frameless type systems. We have not done any frameless procedures. I'm leery as to the accuracy of these things. With stereotaxis, when you make errors, it's not typically off by a little bit. You're off by a factor of 10, or you're on one side of a number or the other. That's why I like things to be very easy to check and very easy to see. And some of the frameless systems are a little bit more difficult to check intuitively where you are. But there are frameless systems out there where you don't have to have that frame mounted. But basically, we're going to be starting up here with an electrode, and we're going to be going all the way down here. So we're going to be going through all these structures, and you want to get that done as safely as possible. And I think a frame's the best way to do it right now. Again, either MRI scan or CT or both. Important to get good images. We do this indirect targeting. We use data based on hundreds of patients about where these structures should be, and that's where we start. And then when we get in the operating room, we electrically find the signatures to refine that accuracy. So this is a slide off of a planning computer showing the trajectory that the electrode is going to take and where it's going to end up. And this is all computerized. There's no slide rules involved or tape measures or anything like that. It's all pretty straightforward, actually. So where do we put these things? Well, there are 3 locations that are currently utilized for movement disorders. The first one that was approved was the VIM nucleus of the thalamus. And although you could use that for Parkinson's disease, we tend not to because it usually only improves the tremor portion of Parkinson's. And most people with Parkinson's, tremor is not the worst of their symptoms. So for essential tremor patients, that's where you put that electrode. If we do a radiosurgical lesion, this is where we put the target as well. And it works extremely well for essential tremor patients. Most of our essential tremor patients are not on any medication after having this done. So I think it's a great procedure for them. For Parkinson's, there are 2 options, the subthalamic nucleus and the globus pallidus interna. And both have their pros and cons. As you can see from the relative sizes, the STN is much smaller. So it's harder to get targeted than the GPI or the VIM. But there are certain advantages to subthalamic nucleus, and that's our preferred choice for Parkinson's disease. One of the things that you can usually do with an STN lesion that you can't do with a GPI implantation, I should say, is that you can hopefully reduce the medication load. So if you're getting a lot of medication side effects, if we can get you on a lower dose, some of those side effects should go away as well. We're very happy with STN stimulation in our Parkinson's patients.